Welcome to this afternoon's session. We're going to be performing a live implant placement. I have several things I'd like to review with you prior to proceeding, but I have to thank the crew here with NMR, the satellite company, and the cameramen who make this possible. We literally have a live satellite feed where we're broadcasting step by step the process of placing an implant at site number 30 for a patient that I've brought with me from Columbus, Ohio. So for those that are here in the auditorium, I hope that you'll get great insight in exquisite detail as to what it's really like placing an implant using the workflow that we've been discussing. So without further ado, I'd like to also thank Bayshore, Dr. Mona Patel's practice here in Milwaukee. Fantastic practice. I mean, to the nines, Mona. Congratulations. Anytime you need an associate, I'm here in a heartbeat. But wonderful, wonderful practice, and it's certainly a vision to see all of these technologies that we've been discussing integrated completely with CEREC, with cone beam, but also here at Mona's office, she's also integrated the Teneo. And the Teneo is a treatment center that allows us to do procedures, but it is considered more of an instrument as opposed to just a chair. In particular, take for example that we can actually have an implantology handpiece built into the delivery system that runs saline through the system, so there's no separate motor. So taken into great detail as to the setting within which that we're placing an implant. And that's very important from an image and a branding standpoint, in my opinion, when you're getting into implantology. So I also want to thank our assistants, Faith and Mariana. I want to thank Nikki and her husband, Wayne, who's allowing us to actually place this implant at site number 30. So Wayne is a young man, non-contributory medical history. He presented to my practice last week with a failing bridge. In particular, it was a bridge expanded from 29 to 31, and 31 was non-restorable. So we sectioned the bridge distal to 29. We had a extraction of the tooth number 31, and we did do an immediate placement of an implant at site number 31. We reserved the Pontic space, which was site number 30, to demonstrate to you the process of doing guided surgery. And last week, I planned for an implant at site number 30 using a restorative vision designed by CEREC, and we showed Wayne and showed the rest of the team, and we agreed on its location. Once that was integrated, we were able to upload that scan to CCAT in Germany, and CCAT was able to actually make us an OptiGuide. So we'll be actually using that OptiGuide today for the placement of an Astra EV implant. It is a 4.8 by 11 millimeter implant. And when CCAT sends that surgical guide, it's assumed that you follow the EV protocol. So before I actually skip to the actual cone beam to show you my plan, I wanted to share with you a few documents that come with the surgical guide. The first document that I find is important is this surgical guide report. Now, the surgical guide report is a summary of your treatment plan for the patient. It includes an image that shows the CAD-CAM impression stitched with the cone beam. But in particular, it's this box down here in the lower left-hand corner that I want you to pay attention to. So if we can zoom into this box down here, that would be great. What you see there is a cross-sectional image with the integration of the CAD-CAM crown, the restorative treatment plan, the location of the implant, the details of the implant down here in terms of which implant we've treatment planned, the model number or the manufacturer number for ordering purposes, and specific details as to how we're placing that implant. It says EV guided surgery. The drill in particular that we're going to be using, we have to use the 23 millimeter drill, which is the 9 to 11 drill with the guided EV kit. Some other measurements that are critical, you can see here in the cross-sectional view, we have a measurement that measures from the bottom of the sleeve, which is that red object inside of the crown, to the apex of your implant, as well as a measurement from the top of the sleeve to the apex of the implant, which measures 21 millimeters. So what CCAT does is they actually set everything up for you, so all you have to do is follow the traditional EV guided kit protocol, which I'll share with you here as well. The second document that I find in all of my guides when they arrive from CCAT is this document right here. It's the Certificate of Accuracy. And what you see here is accuracy within 50 microns, 100 microns, 100 microns, and 250 microns with a degree of accuracy in 0.35 degrees in angulation. And what this does is it certifies that the location of the sleeve in the surgical guide is accurately positioned to allow you to replicate your treatment plan of your planned implant in the cone beam scan. And the beauty of this is that CCAT will not actually send you the guide unless it meets their tolerances. It's one of the only companies that I'm aware of that does this, and that's a fantastic service, so that each doctor knows that great lengths have been taken in the manufacturing process of this surgical guide, and CCAT takes much pride in that work. So that's a fantastic thing that I find that no other guided surgical company provides. Okay? And the last document that I'm going to share with you is our manual for the guided manual from Astra EV. Now, what we're going to be looking at here is the drill sequence, so that when I actually start the procedure, you'll be able to understand how I develop the protocol simply by looking at this workflow here. So we've planned a 4.8 implant, and what the protocol requires are 3 drills. We will first start with the tissue punch, which is right here, the P. The tissue punch has already been provided for Wayne. I did that prior to going live on TV. That tends to be one of the more delicate procedures, and we certainly want to make sure we do a good job in soft tissue management. I will still demonstrate the process of how the tissue punch is administered. The very first drill that we're going to do is the initial drill, which punches through the cortical bone. And since we're placing a 4-point implant, we'll drop down to the 4.8 as you see here. Now in the 4.8 drill sequence, we have 3 drills. The 1, the 3, and the 5 drill. The 1, the 3, and the 5 drill are used for your straight implants. For your conical implants, you're going to use the 1, the 3, and the 4 drill. So today I'll be using the 1, the 3, and a 5, as you see here, followed by a decision to either make the use of the A drill for the cortical drill or the B drill, as you see here. Now in the cone beam scan, as you'll see here in just a moment, we can actually measure the density of the bone. It's relative to Hounsfield, as we can study the grayscale value. And we can also measure the thickness of the cortical bone. And I've predetermined that we're going to be using the B cortical drill, as you see here. Then the last drill that we use is either the V or the X drill. Now the V drill and the X drill are the final drills to prepare the site to receive the implant. The V drill only prepares the apical portion of the osteotomy. Meanwhile, the X drill is used in denser bone to prepare not only the walls, but the apex as well. And because of the nature of my patient's bone, we're a type 1 bone and very dense in the posterior mandible, we're going to be actually using the X drill. So I'll have that prepared as well. Now, unlike my video that I showed this morning, the new Astra EV guided kit is keyless. It's a sleeve-on system. And what I'll share with you is how there's a specific sleeve that's attached to the drill, as you see here in this representation in the diagram. This sleeve allows us to control the angulation and the depth of placement. And these sleeves are attached to the drill prior to inserting them into the surgical guide. So you won't see a secondary element or a key or a spoon that's used in this surgical guide. It's all integrated within the actual osteotomy drill, and you'll see that as well. So without further ado, let's actually go ahead and skip to the cone beam on my laptop so we can actually show the treatment plan that we developed for our patient. So what you see here is actually the cone beam scan that we took last week after the bridge was removed, and implant number 31 was placed with immediate technique. We take an optical impression to design a CEREC tooth, as you see here, to help guide us and to help us understand exactly how to position the implant. This is a restorative virtual wax-up, if you will. And so now that we have the profile of the tooth, we have an opportunity to drop an implant in. Now, the way the implant process works, we have a menu of tools on the right-hand side and in a library filled with all kinds of different implant systems. So you can see here that we have an opportunity to place just about any system that's available on the market. It's all integrated, and the beauty of Sirona's software is that it's volumetric implant planning as opposed to STL model implant planning. So you can see all of these various manufacturers built into the library of the software. Now, for this afternoon, I've selected a 4.8 Astra OsseoSpeed Straight EV implant. Now, the 5.4 would certainly be great to use, but the 5.4 diameter cannot be placed guided due to its dimensions. So the 4.8 is the widest diameter. Now, anatomically, I found that the 11 millimeter in the posterior mandible is sufficient to support a tooth, in particular with the patient who has a brachycephalic biotype, a strong bite, strong biotype. So we have an opportunity to look at the implant, certainly change the sizes, the manufacturer, as well as the model itself. I'm going to go ahead and click cancel so I can share with you how we plan this implant. So the current location is exactly where we planned the implant when we placed the order for the guide, but a clinician has every opportunity to translate the implant, as you see here. We have the ability to tip the implant with the center of rotation being the apex, and also tip the implant at the apical portion, center of rotation being the fixture level. So the ability to finesse your implant position is quite unique in this software. We have full control over making sure that all of the parameters have been met from the restorative standpoint. Let me share with you the actual volumetric plan so that you can see this in much higher definition. So you can see during our implant consult, this is what I presented to our patient Wayne. So we were able to show him the location of the inferior alveolar nerve, the lingual depression in the posterior mandible here, which is obviously anatomy which we want to avoid penetrating during traditional implant surgery. We can also show him the boundaries of the bone, of the osseous structures, the restorative vision and its restorability, and the potential for screw-retained mechanics, as well as the thickness of the tissue and the relative location of the implant to the vital anatomy. This is how we can actually treatment plan our implants while the patients are there in the office on their first visit. Now, granted, if the patient doesn't need any augmentation, soft tissue or hard tissue, and they're a good candidate for implant placement, all the clinician needs to do is go to the surgery tab here in the bottom right-hand corner. Click on this icon right here, which represents the ordering process for the surgical guide. And you can see that we have various options. In particular, last week, I selected this OptiGuide via the www route, which allows us to upload the data to the servers in Germany. And that takes about 5 to 10 minutes, depending on your bandwidth. And as soon as CCAT obtains the data, they can start the manufacturing process of the surgical guide. Generally, 4 to 7 business days for the turnaround time is what to expect when it comes to the OptiGuides. So all of this was done without any analog impressions, no scanning appliances. It's a pure digital workflow. And while we're getting everything set here, you can appreciate this image. I'm going to make my way back to the treatment center here and position myself so that we can actually go ahead and start the guided surgery. I kind of want to set everybody up to show you what we do in our private practice as well. So what you see here is an Optra gate that protects the lip. The Optra gate allows us to protect the lips and shields the lips from our surgical access. We also have an ISOLite here. The ISOLite is fantastic because it provides evacuation, it provides stabilization of the surgical guide as the patient's biting down on the contralateral side of where we're doing surgery. It also acts as a throat pack, as you see here, which is very important when you're doing surgery like this, primarily because there's a lot of parts and pieces, and we want to make sure that the patient does not aspirate the components. Now, I've gone ahead and provided a soft tissue punch, and I'm going to go ahead and try and show the camera the tissue punch through that mirror shot here. So, Sky, if we can zoom in. Sky is my cameraman here on location. We're going to see if we can actually zoom in so you can see the tissue punch through the surgical guide. So the tissue has already been removed. Now, my patient has adequate keratinized tissue. It's not in the aesthetic zone. And so there's some clinical decisions that you have to make prior to using a tissue punch. It's not a question of whether it's easy to do or not. It's a question of whether we have attached keratinized tissue that allows us to perform this tissue punch. Now, I will still show the audience what the tissue punch looks like and how it actually adapts to the master sleeve. But before I do that, also appreciate that master sleeve has a cutout on the buccal. That allows us to actually have better access in the posterior maxilla as well as the mandible, and facilitates the process of being able to insert the instruments due to limitation in vertical dimension. So what I'm going to do now is I'm going to get the tissue punch ready, and I'm going to place that in the handpiece I'll demonstrate to you how the tissue punch fits inside the surgical guide. Here's what the tissue punch looks like. Okay. And you can see that the tissue punch fits precisely inside the master sleeve. I'll step on the rheostat, but realize that the tissue punch has already been provided. The bottom of the black line is the location of the stopping point when we're placing an 11 millimeter implant. So we'll assume that the tissue punch has already been provided, and I'm going to start the process with our initial drill. Now, the initial drill is designed to punch through the cortical bone to help control the first osteotomy. And the reason this is important is often in dense bone, the drill can actually deflect off the cortical bone because we're spinning at fairly slow RPM. I'm going to share with you what the initial drill looks like here. And I'm going to stop right to the bottom of this black line here. Okay? And this will punch through the surgical guide. Now, we have an assistant who's helping to stabilize the guide. I can also use this Minnesota retractor to stabilize the guide on the posterior aspect here. We'll go ahead and insert this. I'm not going to step on the rheostat until I've accessed the site and I have a clear line of draw, and I'm able to passively move this drill through the osteotomy site, as you see there. Then I'll step on the rheostat with copious irrigation. To punch through the cortical bone, and I'll stop right about there. Okay. We'll have the team evacuate the site. And the first drill that I'm going to use is our 9 to 11 drill. The 9 to 11 drill is used with a wide sleeve. The sleeve is already mounted on the drill. So I'm going to share that with you. And then I'll start the drill once I've achieved a passive seat. So you can see, this is the sleeve on drill. The drill has a stopper indicated by this white marking. The stopper controls the angulation, and it will bottom out once we've achieved the proper depth. So I'll go ahead and make sure I have a passive seat. I'll slide the sleeve into the surgical guide. And then we'll tease the drill and the sleeve out of the guide here. Sometimes the sleeve itself remains behind, which is okay. We can grab that with some hemostats and or some tissue pliers. So I'll grab that. Now the throat pack will obviously protect us if this should slip out. There we go. And you can see the importance of having a throat pack there. The next drill I'm going to be using is the 3 drill. Now the 3 drill is wider than the 1 drill. In particular, it's a 2.5 3.1 drill. It also has the wide sleeve on as well. And I'll introduce that into the surgical guide. So this is the number 3 drill. First thing I'm going to do is insert it passively. Make sure I have the right draw. I'm going to slide the sleeve into the surgical guide. Stabilize the guide. And then I'm going to let the drill do all the work using a gentle pumping motion until it bottoms out. Okay. I'll go ahead and grab the sleeve again. Try to pop that out. Next, we're going to go ahead and use the number 5 drill. The number 5 drill is a 3.7 4.3 drill. It also has the sleeve on, as you see here. We'll first insert this into the site, slide the sleeve down the shaft of the drill here. As you see there. And then I'll go ahead and step on the rheostat. Now, one thing I'm sensing as I'm drilling this osteotomy is that our patient Wayne has pretty dense bone. So I'm confirming that with my tactile sensation. Once that's been provided, we'll remove the drill. I'll go ahead and retrieve our sleeve. You see here. Very good. And at this stage, I am ready to actually go ahead and initiate the cortical drill. I've elected to use the B drill due to the density. And in particular, when I show you the B drill, you'll see 2 black lines. I actually want to use this drill closest to the tip as soon as I touch that black line, that first black line there. So this is a visual aid in terms of how we're drilling this cortical drill. And what this does is it prepares the cortical bone so we're not administering too much pressure in the site. And at this stage, I'm going to make a decision to use the X drill. Now, the X drill will prepare the osteotomy not only in the apical portion, but on the lateral walls of the osteotomy as well. Now, the X drill has a sleeve on, just like the 1, 3, and the 5 drill, as you see here. So this is the sleeve that will engage the surgical guide. I'll go ahead and insert this, slide the sleeve down into the surgical guide, as you see there. And then I'm just going to allow the drill to further prepare the site. That's it. Very good. Now at this stage, what we're going to do is we're going to go ahead and remove this sleeve. We're going to go ahead and remove the isolite, the surgical guide. We're going to go ahead and thoroughly irrigate the osteotomy site. This is done to remove any bone chips. It's also done to remove any potential soft tissue tags that are embedded at the base of the osteotomy. So if you would allow my team just a moment to get everything cleaned up here. Faith, I'll have you go ahead and hold this for me. Very good. Thank you, ladies. All right. So let's go ahead and actually put that surgical guide back in. Let me clean that up here. How you doing, Wayne? You doing okay? Great. Okay. So here's the surgical guide. We're going to put this back in. And then I'm going to have the ladies go ahead and situate the isolite back into the mouth as I'm getting the implant ready. So behind the scenes here, what I'm doing is I'm carefully opening up our implant from its sterile packaging. And I'm going to mount the implant directly onto our implant driver, which is delivered by the handpiece. I also have to remember to switch the actual motor for the implant delivery as opposed to an osteotomy. So we're actually going to reduce the rotations to 35 RPM, and I have set the torque value at 35 as well. So it's the 35-35 rule. That's my personal preference. Every clinician has their unique magic number. Okay. Now I have the implant ready. Before I place the implant, I want to share with you some landmarks. The implant driver itself has a couple indications as to the depth of implant placement. So if we look very closely here, there's a notch in this implant mount. I'm actually going to place this implant right before that notch begins. This first line is an indicator for the 11 millimeter implant. So it's visual confirmation from a depth of placement standpoint. Okay. So the first thing I'm going to do is I'm going to make sure I very slowly and carefully insert the implant through the surgical guide to make sure it doesn't bind. And then once I have a path of draw that's clear, I will actually go ahead and initiate the placement. And I'm going to rotate this to right there. Okay. Go ahead and suction for me. So what I'm looking at here, and may be difficult for the audience to appreciate, is I've stopped the implant right at the proper depth. Okay. I'm going to very gently remove the mount, as you see here. And now we're going to go ahead and remove the surgical guide and the isolite. We're going to clean up the site, and then we'll grab a mirror so everyone can appreciate the positioning and the placement of this implant. Mona, I also want to thank you for the black gloves. It's a nice touch. Thank you so much. She knows my style, and I appreciate that effort. All right. So the implant has now been placed. Let me grab a mirror. Wayne, you doing okay? I owe you a beer, man. Okay. The implant has been placed to proper depth. Very good. Okay, so what I'm going to share with you now is the restorative workflow. Certainly, we're not going to be loading this implant with an immediate load restoration, but I think it's important for the audience to observe the process and the workflow for creating a restoration. So we're going to go ahead and put the isolite back in so I don't drop this scan post down the throat here. There we go. Oh, we can do without that. That's okay. And what I'm going to share with you here is the scan post. This is a prosthetic scanning abutment. And what it allows us to do is seat this directly on the implant. It accounts for rotation. Now, while it's outside of the mouth, I want you to appreciate this notch that's right here on the scan post. I have to visually understand the location of that notch because once I've actually seated this, I can actually seat a scanning cap. And that scanning cap helps me to actually locate the implant within the CEREC software. Go ahead and suction for me if you can, Faith. So while I actually screw this in, Wayne, you're doing great. Thank you, bud. Now, this is a prototype. This is not available on the market just yet. So I want everybody to appreciate that this will be available soon. This is just for demonstration purposes only. It's available for the Astra OsseoSpeed TX line, but not for the EV. And I see that my actual notch is on the distal. I'm going to attach this gray scanning cap that allows the Omnicam to detect the scan post. You can see the notch on the gray scanning cap. And I'm going to make sure that I line up the notch correctly. Okay, as you see there. And at this stage, I'm actually going to switch to the CEREC if we could. All right, so the audience can actually see, prior to actually engaging in surgery, we obtain the optical impressions, both for the lower, the upper arch, as well as the buccal bite. Now on the lower arch, you can see that what I've done is I've cut out the location of where we're doing the surgery. So that allows me to quickly capture the scan post. Okay. And now I've captured our digital impression. I'll go ahead and click next and let the image process here. So while this is processing, what I'm actually doing in my patient's mouth is I'm removing the scan post, and then I'm going to seat a transgingival healing abutment based on my assessment of the thickness of the tissue. So this will be a one-stage approach. We won't be required to do an uncovery at a later point. I'll have the team go ahead and thoroughly clean the area out while I get the healing abutment. So you can see that the CEREC data is actually processing at this stage. We'll allow it to finish processing. The buccal bite will automatically stitch. I'm going to go ahead and seat our transgingival healing abutment. Wayne, I'm very thankful and appreciative. You're a great sport. Your implant is in. If we can actually cut to the camera, the boom camera, so I can show the audience, and that way the ladies can get Wayne taken care of here. We've got our implant placed at site number 30. Okay. Excellent. Let's switch back to the CEREC if we could, and I'll walk you through the design phase and show you the flexibility of the system if we were truly ready to restore this implant, the process and the workflow. Okay. And now I'm going to go ahead and click next. Okay. So the first thing it's going to ask me to do on the timeline is to trim the area. So I'm going to go ahead and trim the implant like a die on a final model. Select the correct part. I'm going to click on the head of the scan body so it detects the location of the implant. At this stage, because I didn't do it gingival mask, we're going to go ahead and modify the emergence profile here. Probably going to go a little bit wider on the distal, but not nearly as wide on the buccal. Smooth this part out as well. And essentially what I'm telling the computer is my emergence profile as it comes off of the tie base itself. I'm going to then define the axis for the restoration. Okay. I'm going to adjust this to the mesial, and then I'm going to click OK. Allow it to go ahead and design. And then we can continue to tweak the design of this restoration. Now there's one feature which I really have come to enjoy, which is the BioJaw feature. So if it doesn't give us a decent proposal right off the bat, we can actually go back in and modify our design based off of the BioJaw tools. So it's a decent proposal. I'll actually go now into our shape tools here, and I'll spend just a little bit of time perfecting the shape. But I'll show you how I can actually develop that sigmoid notch in my restoration that I was discussing earlier today. So it's a bit sharp on the buccal here. Usually I'll use the smooth tool, at maximum strength to develop a better emergence profile here on the buckle. Okay. I'll actually go ahead and use the circular tool to actually expand the emergence here to add more material. Like so. A little bit on the lingual as well. And then I'm going to trim the model so that I can actually go to the subgingival component and develop that sigmoid notch. So the first thing I like to do is go to the form tool, smooth, with maximum strength. And I'll smooth out the emergence. By doing so, I'll have a pure convex surface with very little concavity developed. But we want to smooth all of this out. The smoother your subgingival aspect of your screw retained crown or even abutment, the better tissue response you'll have. Okay, so once that's done, I'll actually go in, reduce the strength, go to the remove tool, and further develop that concavity that I was speaking of earlier today. Reduce the size of our brush, and actually go around circumferentially and introduce that slight depression so that it's nice and cleansable and certainly doesn't provide too much pressure on our tissues. Okay. So with that slight depression now introduced, I'll go back to the smooth tool, increase the size of the brush as well as the strength, and really finesse the design here. Now, this actually can then go to the mill stage preview so that you can appreciate how the block itself actually has a screw hole in it. All we're doing is milling the external design, and the tie base is then attached. Obviously, once the restoration has been fired, I'll go ahead and show you the tie base as you see here. I can hide the actual restoration as well. And the tie base is designed to fit the block. You can see that the notch in the tie base is designed to fit the notch inside of the block. And so it helps the software to, it's important for us to develop an understanding as to lining up of the components when we're actually taking that final impression so that the timing or the rotation of our restoration is ideal. So that's the workflow in a nutshell. I really appreciate everyone's attention. Hopefully I didn't go too slow or too fast. Hopefully it was right down the middle of the row and everyone could follow. But that's an appreciation for the Astra guided solution. And you can see how it all fits together, from scanning in cone beam, scanning with the CAD CAM for design of your implant location, having Sirona actually fabricate the surgical guide, then providing the treatment through a guided solution, followed by the restorative process. Once an implant is finally healed, certainly you would engage that component. But I was able to actually show you the entire workflow today from start to finish. So I appreciate your attention, and let's hand it back to you for questions.